All right, let's dive into one of the most common and, frankly, most complex topics in medicine, breast cancer. Over the next few minutes, we're going to walk through a really concise, clinically focused primer. It's designed for you, the medical trainee, and we're going to follow the exact path you'll take with your patients, from their very first risk assessment all the way to advanced treatment.
So here's our game plan. First, we'll get a sense of just how big this disease is. Then we'll jump into the proactive side of things, identifying patients who are at high risk. From there, we'll cover how we define the battlefield with staging. Then move on to curative treatments for early-stage disease. And finally, we'll wrap up by exploring the strategies for managing cancer once it is spread.
Let's start with a single, powerful number that really frames this whole conversation. 1 in 8. That's the lifetime risk for a woman in the U.S. to develop invasive breast cancer. It's a number that makes it crystal clear why every single one of us needs a rock-solid foundation in this disease.
Okay, let's kick things off by getting a real handle on the true scale of this challenge.
So looking at the big picture here in the U.S., breast cancer is the most common cancer you'll see in women, if you don't count skin cancers. Now, the median age at diagnosis is 61, but you have to remember, it can affect women at pretty much any adult age. And here's the kicker. Even with all our modern advances, it is still the second leading cause of cancer death for women. These are the fundamentals we build everything else on.
That brings us to the really crucial upstream work: risk, genetics, and prevention. You know, this whole section is about figuring out who is most at risk before a diagnosis ever happens, and what we can actually do about it. You know, this table makes one thing incredibly clear. Not all risk factors are created equal. Sure, things like lifestyle definitely play a role, but the relative risk is just dwarfed by factors like having a BRCA gene mutation or a history of chest radiation for something like Hodgkin's lymphoma before you turn 30. These are the massive red flags in the patient's history that you absolutely cannot afford to miss.
Now here's a really critical point for your clinical practice. The guidelines for who should get genetic testing, they don't always agree. Just look at the different age cutoffs between the NCCN and ASCO-SSO guidelines. The NCCN also casts a much wider net, looking at family histories of other cancers like pancreatic and prostate. Understanding these differences is so important because it directly impacts who you can get testing for and how you advocate for your patients.
So once you've identified a patient as high risk, what's next? Well, we act. We intensify their screening, often adding breast MRIs to their yearly mammograms. We can offer chemoprevention with medications that actively lower their risk. And for those at the absolute highest risk, like BRCA carriers, we have the option of prophylactic surgeries that can literally slash their cancer risk by over 90%.
Okay, now we're going to shift from risk to what happens after a diagnosis. We're entering the world of staging and prognosis. This is where we define the battlefield.
So staging is basically the universal language we all use to describe how far a patient's cancer has spread. It's built on that classic TNM system: tumor size, lymph node involvement, and metastasis. And honestly, it is still the single most important factor that drives both the prognosis and our initial treatment plan.
This progression just starkly illustrates the power of early detection. I mean, look at this. The 5-year relative survival for stage 0 disease is nearly 100%. But just watch what happens when that cancer becomes distant or metastatic. It plummets to less than 30%. This one slide shows you exactly why screening and early diagnosis are the absolute cornerstones of what we do. But, you know, prognosis isn't just about the anatomical stage. The tumor's biology is hugely important. Is it being fueled by hormones like estrogen? Does it overexpress a growth factor protein called HER2? These biological markers, along with things like tumor size and grade, give us a much more detailed picture of a patient's likely outcome.
This brings us to treating early-stage disease. Now, for any patient who has stage 0 through 3 cancer, our primary goal is simple, and it is singular: cure. So, what you're looking at here is a classic mammogram showing ductal carcinoma in situ, or DCIS, what we call stage 0 cancer. You see those tiny clustered bright spots? Those are punctate calcifications. They represent non-invasive cancer cells that are still completely confined to the milk duct. Now, while DCIS itself isn't life-threatening, we treat it aggressively because it's a critical precursor to invasive cancer.
Once a cancer becomes invasive, the surgical conversation usually involves two main paths: breast conservation, which is a lumpectomy followed by radiation, or a full mastectomy. A key part of that surgery is staging the lymph nodes under the arm, and today, the modern standard is a sentinel node biopsy,
It's a much less invasive procedure that helps most patients avoid the significant side effects of a full node dissection.
Get this, about 3/4 of all breast cancers are hormone receptor positive. What that means is their growth is literally fueled by hormones like estrogen. That single fact is a total game changer because it gives us a powerful targeted therapeutic tool for the vast majority of our patients. And that tool is endocrine or anti-hormone therapy. The two main types are tamoxifen and aromatase inhibitors, and the key difference is how they work. Tamoxifen blocks the estrogen receptor itself, so it works in all women. Aromatase inhibitors, on the other hand, shut down estrogen production outside of the ovaries, and that's exactly why they are only effective in postmenopausal women. So what about chemotherapy? Well, today, that decision is driven almost entirely by the tumor's biology. For aggressive subtypes like triple-negative and HER2-positive, chemo is almost always recommended for tumors bigger than 5 millimeters. But for the most common subtype, the HR-positive, HER2-negative cancers, we've entered an era of personalized medicine. We use genomic tests to analyze the tumor's genes, which lets us predict who will actually benefit from chemo and, just as importantly, who can safely avoid it.
Finally, let's shift our focus to metastatic cancer. Because when the disease has spread, the entire landscape and our goals of care, they change dramatically.
This quote really captures the fundamental shift in mindset. With metastatic or stage 4 breast cancer, our goal is no longer a cure. Instead, our focus becomes extending life, controlling symptoms, and preserving a patient's quality of life for as long as we possibly can.
Okay, here is one of the most important takeaways for your future practice. Always biopsy a site of metastatic disease. Why? Because a tumor's biology can actually change over time. An estrogen receptor-positive primary tumor can give rise to an ER-negative metastasis. This happens in up to 15% of cases, and confirming that change can completely alter our entire treatment approach.
This table really shows how modern treatment is precisely tailored to the cancer-specific biology. For HR-positive disease, we now combine hormone therapy with drugs called CDK4/6 inhibitors. For HER2-positive tumors, we use dual HER2-targeted therapies. For some triple-negative cancers, we can now add immunotherapy. And for patients with an inherited BRCA mutation, we have a class of drugs called PARP inhibitors. This, right here, is the definition of personalized medicine.
And this all brings us to a final question for you to carry forward. The pace of change in oncology is just relentless. Our therapies are becoming more effective, but they're also way more complex. As a future clinician, your role won't just be to know the evidence. It will be to translate it, to personalize it, and to navigate these incredibly difficult decisions right there alongside your patients.